afternoon. I think we're going to go ahead and get started. We thought we'd have a much more massive crowd on the auspicious ICD-10 rollout day, you know. But here we go. Just a little bit about this panel discussion that we're going to have. Basically, the focus is going to be on being able to provide some history of DSM and ICD, being able to look at the synergy and functionality between these two classification systems, and the classification system and the diagnostic system, and look at two counties' sort of real-world implementation of ICD-10. So with that, I'm going to introduce our panel. To my right, we've got Singh. Vic is the Director of Behavioral Health Services for San Joaquin County and has held that position since October 2007. Prior to that, Vic held a variety of administrative and service positions during his 33 years of public service in 4 counties. His positions have ranged from county administrative officer to deputy probation officer. He's also an LCSW, having first received licensure in '82. He received his undergraduate studies at UC Davis and received a master's degree from CSU Sacramento, where he has received recognition as a distinguished alumnus. He's also a senior fellow of the American Leadership Forum, Mountain Valley Chapter. And before I move on to introduce Bill Walker, I need to say who I am. I'm Percy Howard, and I'm the Chief Program Officer at CIBHS. Next, we have Bill Walker, and Bill is the Director of the Mental Health Department in Kern County. He's responsible for the administration of publicly funded mental health crises, substance use disorder, and prevention services to adults, adolescents, and families. His other responsibilities include oversight of a multi-million-dollar budget, including federal and state categorical funds, program planning and development, program evaluation, contract management, quality improvement, client problem resolution, strategic planning, budget forecasting, and human resources and personnel services. We also have Dan Walters, who is actually on the phone with us, so he will be joining us sort of from the ether, okay? Dan is a manager of technology services for the Kern County Department of Mental Health. He managed the successful implementation of an electronic health record system from the Cerner Corporation, which was formerly known as Anasazi Software. He oversaw Kern County's implementation of ICD-10, CM, and DSM-5. Dan is the chair of the CBHDA SWAT team, a committee of providers and vendors working with DHCS to communicate and resolve computer and process issues between the counties and the department. We also have with us over here Dana Sizemore. And Dana is the Kern County EHR systems analyst who has been instrumental in the rollout of ICD-10 in Kern County. So with that, we will start, gentlemen.
Well, thank you. I'm going to turn it over for a second to Vic, but I needed thank you for, this is the last event of the day, and we may be the driest event of the day. So I appreciate all 20 of you that are still in the audience. And I wrote a joke for the occasion, so I'm going to start with the joke, and I'll turn it over to Vic to give some introductory comments. So a DSM-4, a DSM-5, an ICD-9, and an ICD-10, and an ICD-10 CM, and a blue book all went into a bar. Now, I hope you appreciate there's a dual diagnosis flavor to this, so I had to work at this. And they couldn't order a drink because none of them knew how to use barcodes. Yes, it is the end of the day, and that's why everything is funny at the end of the day. So with that, this really is a very serious topic, and we're hoping to do it justice, and I'll turn it over to Vic to give us some opening comments.
Thank you, Bill. You know, it might be worth observing that there was a palpable relief this morning after Karen Baylor's remarks about the implementation, and she gave some suggestions, and during the course of the presentation, we'll talk about where we're heading and what we're recommending and how it seems to be dovetailing with her remarks this morning. And so, but that was very helpful and very much appreciated by Karen. So I want to just set the context here a little bit. So why are folks so anxious? Why is it that we don't have a yellow brick road leading us on what we should be doing right now? That's true of the state, DHCS, counties, different counties doing different things. Why isn't there this requirement? Why are we here? And I think it's worth remembering that there's been a lot of stops and false starts and rumors associated with the implementation of ICD-10. 2 years ago, we were given the date of October 1, 2014 as the implementation date. And then that date was changed. And then 8 months ago, there were still rumors around the country that the October 1, 2015 date was going to be extended. And there certainly was a lobbying efforts by many, probably most noteworthy, the American Medical Association, which is very, very powerful. So because we all have such an amazing amount of work to do, no one wants to start and prepare if they don't have to. And so I think that's in large part what's happened. Everybody was waiting to see if there was going to be another change. And so we're all a little behind as a result, but I don't see any blame or any fault to assign for that. You know, and then there was other pieces. For instance, when the DSM-5 initial printing came out, it was found that there was 300 coding errors as the DSM-5 tried to guide folks from a description to a coding and diagnosis, and that was those errors when the ICD-10. So we're thinking, well, wait a minute. Some of us are thinking we have to use the DSM-5, but it's got all these errors. Well, they've all been fixed, but that just sort of set more rumors into flying about. So I really just wanted to set the context that Karen's remarks this morning were very, very helpful, I think, in relieving anxiety. Bill?
You know, we're going to use a PowerPoint, but I want to make a comment about Karen's presentation this morning. If there's a good takeaway for anyone in leadership, that's a really good way to lead. There's all kinds of issues that have to be done and resolved and fixed. She brought her team forward. She praised her team. She supported them. She supported us. And it's like, I thought that was a really good model for how to deal with difficult areas. So I was very appreciative of that. The first slide you see up there already, there's a point in red that's kind of hard to read, so I'll read it to you. It says, positive effort to use the most accurate diagnosis to treat with the most effective and efficient treatments. As we move forward through all of this, that's what we have to keep in mind. It's really about, as we move into evidence-based programs and practices, is trying to make sure we're bringing the right resource to the right condition and to model with that. If you just kind of follow through, you'll see first we're going to hit a little history, and the first history is to look at the ICD-10 CM. Now, CM is important because that stands for clinical, you see in the first bullet, it stands for clinical modifications. There was an ICD-10 that came out first, like an ICD-9, and then an ICD-9 CM. And the CM is modifications that they've added to it. On the third bullet, you'll notice that the release date for the CM version was 1999. The ICD-10 itself came out in the early 90s, like 90 to 92. And it's the mandated last bullet for use for all claiming activities. So it's very important that we understand what the ICD is for, and it's for that coding and billing. I don't know if you want to make a comment to that one. On the next slide, and Dan, just jump in if you need to make a comment. Just reach out and grab Dana through the phone. More on the ICD-10 history is in the second bullet, you'll see that the clinical modifications were made specifically for the U.S., and it was actually specifically made to dovetail with that current version of the DSM, because these don't get published at the same time. They're published by completely different groups, and so the CM versions often reconciled for the need for the coding to appropriately work with the current version of DSM. And you'll notice in the last bullet that they're working in an ICD-11, but it's been delayed until 2018. On the next bullet, the DSM-5, I think that's what most of us are more experienced with. And you'll see in the second bullet that that version was released in 2013. I was looking through some history just for the fun of it, and I have a DSM-2. And the DSM-2 is not much thicker than my phone. I don't know if you've seen one of these. And then I have my DSM-5, which is probably almost as wide as the base for this microphone. It's just radically different. And the DSM-1 actually came out in the early 50s and had 106 diagnostic categories. The DSM-2 came out 16 years later in 1968, and it had 182 disorders. And then 12 years later, we have the DSM-3 in 1980, followed by the DSM-3R, and then DSM-4, now the DSM-5. And for the most part, it's getting less and less time. But because the ICD-10, that currently is in use was really reconciled to the DSM-4. Most of you, if you've looked at a DSM-5, they are radically different. And so the DSM-5 is probably one of the biggest overhauls we've seen in the last 25 years of that manual's diagnostic processes. I have to quit saying Axis 2 now. It blows my mind. So what is the relationship between the two? Well, clinicians, as you know, use the DSM, and for almost all systems, the ICD version was an electronic crosswalk. And I refer to this as the Reese's Peanut Butter Cup. You know, if you remember that commercial where two people came together and they bumped into each other and, you know, how'd you get your peanut butter in my chocolate? How'd you get your chocolate in my peanut butter? Well, for years when I was a clinician, I'm still a clinician, but when I was doing diagnosing, I never cared about the ICD, paid no attention to it whatsoever. Some computer thing fixed that for me, and then it sent a bill in, which I didn't care about as a clinician either. I was an end user, you know, and I was providing direct services, probably Vic too, and we didn't care about it. And we didn't care that all our computer people kept updating them, but the problem is the wheels kind of fell off at this point because the DSM-5 and the ICD-9 are so far apart in years, or the DSM-10, that they don't reconcile directly. They don't easily crosswalk, and so other things had to occur. And Vic had already mentioned, as many of you know, the problems that were inherent with the original DSM-5 anyways. So it didn't make it any easier to try to figure out how to make this work. I don't know if you want to.
Well, I would observe that I actually started my career using the DSM-2, and it really wasn't much of an exaggeration to say it was really just a thick pamphlet. And you'll see how important the changes are later into the presentation. But among the things I remember was deciding not to update the official ICD-9 diagnosis because it took me doing some extra paperwork. And so I didn't do it. I kept my DSM-2 diagnosis updated, but not the ICD-9. That's how inconsequential it apparently was, at least to the clinical staff at the time.
So we're dealing with a DSM-5 that came out in 2013, reconciling to an ICD-10 that the CM version came out in 1999. Just think of even some of the way we say things differently now versus then. Abuse versus substance use. There's so many little things that we say differently and that they're not reconciled in the languages of these. So if we go to the next slide, this is just one example. And I don't know if it actually, oh, he did one of those things to it. So if you were tired now, I want you to be completely amazed at what you're seeing on that screen. We're not going to go too far into the weeds in some of these examples, but what you're going to see is some of the misfitting of diagnostic categories, which makes it very difficult just to do electronic crosswalks. And so here's an example from the DSM-5 to the ICD-10 of the major depressive disorder, and then if you go down one particular rabbit hole, it actually leads you to a different disorder. Why does this become important? Because if you actually build one code and they come out and do a review of your chart and you're actually documenting a completely different disorder, you know, that becomes a real issue for the audit. Or if someone is taking that chart over, they may look for the diagnosis and see the client's got a diagnosis that doesn't seem to fit what the client's symptoms or treatment are. So we find several of these little misfits, and as Vic said, as they've corrected some things in the DSM, no changes have been occurring in the ICD-10 CM. And so how these things come together still will require more and more work on our part and with DHCS. We have a great partnership with CIBHS that also is, we actually for our county brought CIBHS to do trainings already in both DSM-5 and ICD-10, and they are just great trainers and assets to us for this. Now again, some of the differences, again, this is an example of Asperger's and autism, and you'll see in the DSM-5, they have the Asperger's syndrome put into what they call the autism spectrum. But if you go to the 10, they actually list more broken out disorders, and then all of those disorders are in the included diagnostic category. So this is an oddity of, if it's now coded one way in the DSM, but if you were to look at what you're going to code into the ICD, which is what you're going to bill for, you could actually choose different specificity. So either through your electronic crosswalk or through the decisionals you set up, then you want to be consistent. Where it gets kind of bizarre is, now how do we compare data across counties or across the country if that isn't a crosswalk that's solid and requires some decisionals? It could be done differently by different computer systems may set up to do crosswalks that crosswalk them differently. So we know that we're not out of the woods as we move into this, which brings me back to the way Karen presented earlier, which is, well, we know we're not out of the woods, but you're not going to get out of the woods, you know, sitting in a minefield. You're going to keep moving forward and then fixing one thing after another. I don't know if you want to comment.
Well, I think bottom line here is that the DSM-5 is not perfect. I mean, even though the goal of the APA was to create a document that could be used that culminated in an ICD-10 CM diagnosis, they weren't perfect. So even though that was their goal would have been perfection, for whatever reasons, it didn't come out that way. So that's just what to take out of this slide.
So we're going to look at a couple other just interesting differences on the intensity levels. If you've studied with the ICD-10, you know that it has different intensity levels worked in, which aren't the same as what you see on the DSM-4 or 5. And so again, it requires some system to make decisions about how these are going to occur. The next slide shows similar things on the substance abuse side. Again, if you have any history with departments, you remember when we were talking about abuse and not abuse. One thing I find kind of interesting on this one is you look at the column for ICD-10, the second one down, you have alcohol abuse with intoxication. I used to run crisis systems. I used to jokingly say to our drug and alcohol administrator at the time is that I run the crisis systems, the hospitals and the emergency rooms. We treat people who are intoxicated, who have drug problems. I said, you guys treat people who are clean and sober who have drug problems. There's a radical difference. And it was kind of a joke because a lot of times in programs, the person isn't using or not using to the significance. And it's interesting that in the DSM-5, it doesn't even have that as a category choice, but it seems like something that makes sense to me that it would be there. But again, it's how we will systematically, both at your county level in preparation for your audits and then across counties, and then it would be great across the United States, understand how we're going to crosswalk these things. So Rome wasn't built in a day. It was built. I think it also fell down too. So we don't want that analogy in the long run, but we at least want to build it.
Bill, this is Dan. If I could just throw in one other comment on this slide. Notice the difference that ICD-10 is still talking about terms like abuse, use, and dependence, whereas DSM-5 is defining everything in terms of an alcohol use disorder with or without various additional functions. I think it's important to recognize that DSM is moving away from the abuse and dependence kind of categorization, whereas ICD-10 it continues that the use of those terms. I think that's an important thing to notice as we move forward.
I think that's a great point, and I think that's one of the things, again, we'll have to keep looking at how that works within the crosswalk of systems.
We will, and just to point out real quickly, that's probably in large part a cultural issue, so that internationally various countries use different emphases and different language. And in our culture, in the United States, we're I don't want to say softening up, but we're modifying how hard we've been on addicts and addiction. And I think you see it reflected in the almost softening of our language.
So our next section of this, which I thought was going to hit some of the more controversial issues, and maybe it still will, but I think Karen really helped us out on that this morning, is the implementation strategies. The easy one is today is the hard date for, it's the October 1st. If you didn't know you were supposed to be sending in all your codes in ICD-10 CM, you should probably discreetly leave now. And I would just keep going to Mexico at this point. I wouldn't go back to my county. But I think everyone knew that part. That was the hard line. The other line, though, is that, well, how am I getting to the ICD-10? Am I fully implementing DSM-5 and doing an electronic crosswalk? Am I doing DSM-5 and a manual crosswalk? Am I not doing that? I'm staying with 4 and letting it go to 9 and let 9 through my electronic medical record do a crosswalk. There are several different options for doing this, and so let me first say that there isn't one right answer to this. Part of it has to do with what the county and the county structure and how that county works with its contractors and what everyone's needs are. What I really appreciate is what I thought was going to be the most controversial issue is the acceptance of any of those methodologies. And I talked with Karen at the lunch break, and she said, yes, if you're using DSM-4, DSM-5, Blue Book, any of those appropriate acceptable processes, and you're transitioning either through the 9 to, as long as you're turning in the 10, when they come out to audit you, they will look at what you used to substantiate that diagnosis. They're not going to mandate at this point that it's 9 or 10 or 5 or 4 or Blue Book. Now, I do believe that she expects that counties are moving to the 5 and that DHCS may give us a hard date on that. So we haven't got that. That should be something that they'll provide to us in writing. And if there's issues with that, take that please back to CBHDA. They have a great relationship to try to hammer these through. There's no effort to try to put anyone in a bad position in the transition is, I think, the most important takeaway from that.
It's a good point. And I suspect, although we'll double check with her, I suspect she had a communication at the federal or national level from the Centers from Medicaid and Medicare, basically saying, paraphrasing, we were in part responsible for there not being this yellow brick road and what to do or where to go. So we're going to give you a little bit more leeway. I mean, I'll be interested to read, and I should have checked on the internet, and I didn't get a chance today. I'll be interested to read, though, tomorrow, just how many large hospital systems were 100% compliant or struggling with various levels of compliance. I mean, it's just been a very, very uphill challenge to implement the ICD-10 CM.
So the next slide is Plan A, and Plan A isn't necessarily like the best or right plan. We just Plan A, Plan B, Plan C. Now, there's a great place down in Cabo. I don't know if it's anywhere else, but it's a shirt shack that sells There Is No Plan B shirts, and if you've ever been there, every shirt they have says there is no Plan B on it, and there'll be some slogan or whatever. Well, there is a Plan B here, but I like the shirt. So if you're ever in Cabo, you got to look up the There Is No Plan B shirt. And I'm not wearing my glasses, so I can't see far enough away to see if anyone smiled at that. So Percy, if you can keep an eye on the audience for me, I would appreciate it. So Plan A, this is one way of doing it, is implement your ICD-10 CM well in advance. Now, if you haven't done this already, you're not going to do it. But one option is also to implement your DSM-5. And the way this would work is you would have a crosswalk from 9 to 10, but that's many to one, so you can update your diagnostic reviews and actually implement ICD-10, and up until today, crosswalk back. It's actually easier to do, and submit your ICD-10 billings as you always have. And so at the day today, you just kind of flip a switch, and all your records are already in ICD-10. This happens to be what our county did. And so we've spent the last 90 days converting, well over 10,000 records into ICD-10, and we've started doing our DSM actually about 60 days ago as well. And it was very labor intensive, but for us, the reason why we did it is that we were training ICD-10 CM and DSM-5 together. I wouldn't say that's the best process, but it's the process we did, and it avoided some other things for us. But again, you either did that or you didn't, so I don't know if there's any reason to spend much time on it.
Well, I think I would observe that I was very tempted to try and implement this approach in San Joaquin County. It made all the sense to me for technological reasons and because of the state's waffling language. I decided not to do it ahead of time. I also didn't think that there would be the necessity of updating all of the diagnoses by September 30th. I thought that would be an ideal but not a requirement. So, because I just thought, this is a billing requirement in essence, and so we could have implemented it, after October 1 as we went along, but using DSM-5 and ICD-10.
And I'll do the CIBHS shout out again, is that as moving forward, we believe it's important that the staff at the staff level now who do the assessing understand the DSM-5 and the ICD-10 CM. No longer just DSM and let it be what it is, because there's decisionals that need to go on. And the shout out to CIBHS is that they do have the mechanisms to provide training to counties on those particular elements, and they do a very excellent job with it. So regardless of when and how you're doing that over the next months, please consider the assets that are available to you. Now, I said there is no plan B, but there is a plan B. And this plan B is to crosswalk from the DSM-4 to the ICD-9. That's what is happening right now. As of yesterday, that's how I think everyone's billing for the most part was going in. And this is a pretty easy crosswalk because they were set up to crosswalk. And then you do the ICD-9 to the ICD-10 CM. Now, this part has some, as you see in the bullets, there's some difficulties here. I do believe that every electronic medical record that counties are using right now has the capacity to do it, but there's still some odd decisionals that are going to occur in this process. And the survey that we sent out, 65% of the responding counties indicated that they were going to depend on the crosswalk. And so it is the easier of processes. It has its own risk. And I think initially this is the process you guys are using?
Yeah, this is what we settled on, not because it was perfect, but because I thought it was going to be technologically feasible for us and that it would create the least wear and tear on my staff as I train them. So what we decided to do is we took a guess and we said, we're going to implement and require DSM-5 internally along with ICD-10. So it was going to happen electronically starting today. So my clinical staff were going to continue to use DSM-4. It would then translate into ICD-9, which would then crosswalk over to ICD-10. Because DHCS had given us what the included diagnoses were, and I think they knew that a lot of counties were going to need to go this way if they were going to be timely. So this is the route we took, and so what we did is what we did say, we let all our staff know what we're doing. We're going to implement ICD-10 on October 1. You don't have to do much about that, though. You just continue on. But we are not happy not using state-of-the-art tools, the DSM-5. As many of you know, we hire a lot of new graduates that are trained in DSM-5, et cetera. So we're going to try and bring this all together the way we thought, had we the time, we would have done ideally today, but we're going to lag until January 1. And I was secretly a little pleased because that's the date that Karen threw out this morning. She could change her mind, and because it might be early for some counties. But we're going to, in San Joaquin County, continue to shoot for implementation of DSM-5 and ICD-10 CM on January 1 of 2016.
So if your county is doing this, the next couple of slides, I'm not going to go into the weeds in them, but I just want you to see again that there's going to be complications. That your electronic medical record, if you're completely relying on it to make the crosswalk, it's making some decisions. And so this PowerPoint is posted up, and so you might want to go look and see what your electronic medical record is actually deciding on some of these diagnostic areas, because without going into the weeds, there isn't a one-to-one correlation in between 9 and 10. 10 has many more diagnostic categories than 9, and so somebody is making a decision in some of those areas. Some of them are very clear. In our county, we actually made a list of several diagnostic categories that we knew were confounded enough that the computer or a human is making a decision of choices, and now we're going in where you are in them. We're pulling those particular charts to see, one of the things we're looking for are people just defaulting to the most generic choice, or is the computer doing that if a computer does it? And your IT can do it if it's a computer part, probably humans if you're doing it in a crosswalk. So here's one example.
Bill, can I comment that, Dan Walters in Kern County and Bill did a wonderful job on this PowerPoint. It's the best one and the most helpful and informative that I've seen. And yet when I shared it with my staff, they had some disagreements on the diagnoses, on how it was crosswalked. And I'm thinking, boy, so food for thought. Nothing's going to be perfect here, and your county's going to have to work it out for itself, and then we're going to be able to have to bring some of those issues to the attention of DHCS and work them out in advance of audit time. So But I do really want to give a sincere shout out to Dan Walters and Bill in Kern County. They really did an excellent job in breaking this down so that it's understandable for folks. And they've shared this in other venues. So again, just yet again, another shout out.
Well, thank you. Dan, the reason why Dan's on the phone is he couldn't be with us, but he's the one who actually did virtually all the work on our PowerPoint. And actually running the SWAT team, he's worked very closely with both DHCS and the CBHDA Health and Information Committee to keep working through these things. And so, again, as he said, things are not clear. People don't always even agree on what they're disagreeing on. But as if you see anything from your county, please pass it forward to your representatives at the Health and Information Technology CBHDA subcommittee, and then we'll keep working it out. So the next example is just some issues about schizophrenia, and again, the ICD 9 to 10 changes and how they're just not a direct link. And if you keep going and look at substance abuse examples, again, they're not direct links. In the short run, is that going to be an issue? Well, maybe not. But in the long run, if you move into DSM-5, then you'll just be dealing with the conversion from 5 to 10 versus from 4 to 9 to 10. And so trying to convert from ICD 9 to 10 is a different problem than converting from DSM-5 to 10. But you can't go from DSM-4 straight to 10. You'd have to go through the 9. Now, it's like, what time is it? It's after 4 o'clock, and I can't even believe I said all that. And you're not laughing at any of it. I am so sorry for that. But, and I'm a director of the department. I'm the one who signs that says this is the right bill and this is all good and right. And so, it's a big deal. And I did all my work was not to be a director of a mental health department. It was to be a good clinician, provide good care, understand what I'm treating. If I go in for a medical treatment, I want them to know what they're treating, because if they can solve it with an antibiotic, I want an antibiotic. But if it's not going to be treated, if that won't do it, I don't want to just go through trial and error. I want to be treated right medically. And psychiatric is no different. We want to make sure we're treating and then providing the right treatment. There's another substance use example, but I'm going to move it straight into Plan C. Now, Plan C is similar to Plan A, and specific implementation of this depends on your electronic health record software you're using. But once an ICD-10 CM diagnosis is entered into your system based on your 5 diagnosis, should be able to submit claims using the equivalent ICD-9. And again, I don't think I want to belabor this, but you should, in your county, already have a plan of what you're using. But know that today was the hard date for ICD-10 CM, and probably within the next months, DCHS will probably give us a hard date, or at least some period of date for DSM-5. And even today I had someone saying, hey, I don't think we should be doing the DSM-5. I heard them talking about that in a conversation. And I'm not, I don't work for the APA, or I don't get any money, but every doctor, every therapist, every program we're hiring from, you made the comment as well, they're all getting trained in the DSM-5. And although it's flawed, every DSM has been flawed. I have a very good friend of mine is gay, and I found a DSM-2. Mm-hmm. And you know what's in the DSM-2? Being gay is a diagnosis in DSM. That was the last DSM that had it. So I asked him, I said, I don't know how you'd feel about this, but he does awareness trainings and stuff. I said, would you like it? He goes, yeah, give it to me. I want to be able to take that, up forward. And so there's no flawless DSM. And so I gave him the DSM-2 that I had found, and we both looked it up and looked at it, and it's like, wow. What will we look at the DSM-4 or 3 or 5 later and go, we really didn't really have that right, did we? So
just real quickly, just the ICD-10 always relied on a guide for its use, or the clinician's knowledge base. So the clinician can know and then apply the code, looking it up in ICD-10, or the clinician can use the guide and then know and then apply the code, the diagnostic code as per ICD-10. it doesn't look like ICD-10 was meant as a standalone by itself. And then, and we'll talk further about, what the best option is.
So what does this mean? As we said earlier, we all know we use the DSM-5 to actually formulate a diagnosis. We use the current ICD to set the code for billing that diagnosis. There is no definitions in the ICD sections. It's just the name and the number. All of that is the DSM. So this is our Reese's Peanut Butter Cup that we're trying to put back together as a Reese's Peanut Butter Cup. So we believe that your best form is to train clinicians in DSM-5 and ICD-10. We believe that there are many straightforward crosswalks. It's actually if you've not looked at the DSM-5, many of them show the exact coding right there, and it's a direct choice. But when it isn't, you want your staff to be trained in how that works. I don't think, what I found from our clinicians is doing it together made sense to them because they're used to going through choices and menus and 2 of these and 4 of those and whatever, and then, it's this diagnosis and, is it with this or without that, and then saying, okay, it's this. We're just kind of adding another layer to it and saying, and is that a direct number here? Or is that some choices here? And if it's a choice, which one is it? And so we've opted to give our clinicians training to have complete discretion. Now you can make that last part more of a crosswalk electronically. We've chosen not to. I'm not saying that's the best way, but it leaves the clinician most empowered with the client they're working with to make sure they're trying to pick the right choices that fit their clinical pictures and needs. Now, I'll go to the next slide. There is
Bill, I think it's worth pointing out that a lot of people consider the Blue Book a potential alternative, and I guess it is, but I think we really can't forget that the Blue Book was really designed for ICD-10 International. Right. Not ICD-10 United States, which is ICD-10 CM. So it never was designed for the United States. So again, another rationale for maybe to consider the DSM-5.
You find that language was never updated like the CM version was updated. By the way, most of these things I didn't know 9 months ago. I don't know about you.
Same here.
So what does it all mean? We talked about, actually, why go to all this trouble? Well, the second bullet, clinically, the whole point of ICD-10 is to provide more information about the client's condition. The 4th bullet about common language, how do we do research unless we're actually agreeing on what we're actually working with and diagnosing? And in the 5th bullet, fiscally, auditors could disallow services if the diagnosis doesn't fit, if we're actually just using crosswalks and then we don't look at it and we end up we're documenting to something that isn't what the diagnosis actually shows. Now, there's an example here of how that could happen, and just trust me, it can. So I want to move forward because I want to get to the psychosocial and contextual factors. Now, again, there's some new things in the DSM, and I'm going to go through this very quickly because if you've not gone through training in the DSM-5, you really need to go get training in the DSM-5. But you probably know that it doesn't have the same access codes, and it just codes things radically different than any model we've ever had before. It's kind of like, have you ever heard about the e-ticket ride at Disneyland? Well, you just dated yourself if you remember that, because when did they last have an e-ticket ride? It was decades. And so I'll probably be saying access 2 for a long time just because I'm used to the term, but it doesn't exist anymore in the DSM-5. And so you'll see in here that you start getting into your Z codes and your V codes and how these different things start working out differently. And one solution is to start to figure out how to crosswalk these, but really the thing that I'd like to get to is the next slide, which is you really don't want to get into the weeds on these subcoding systems. You really want to stay with your main diagnostic codes and make sure that you're coding those correctly. The others are helpful, but what you'll find is that there are hundreds, if not thousands, of little subcodes that you can get into. I think at the local hospital, they've got some really funny code, and they've got to post it on the wall, and has something to do with some really obscure thing that someone could have happen to them, and it's a code in the new ICD-10. And so I didn't want to put too much energy into this, but I want you to be aware, especially because it can distract your staff, as your staff could start seeing this stuff and go, oh, well, what are we supposed to do with this? What are we supposed to do with that? Just like the V codes were not what we substantiated medical necessity code on in the earlier DSMs, these coding systems are meant to augment and specify. They're not meant to justify the primary diagnosis in ICD-10 CM. And
Well, I think another way to handle it is rather than put it in a code, oftentimes it's included in the narrative. It's included in the assessment, and it's included in the updated progress notes. So it's not that the information isn't important, it's that it's more difficult than maybe it needs to be and is worth to use the ICD-10. So don't get hung up there. If we realize that maybe we need to go back to it, we can go back to it. There's no harm, no foul, especially in terms of the billing. And I think the information is there in the clinical record because it's almost always in the narrative. You don't actually code something that usually isn't also found in the narrative.
so how do you document a diagnosis selection? Well, in the DSM-4, DSM-5, ICD-10 Blue Book, ICD-10 Tabular Index, clinicians currently are familiar with documenting diagnosis using the DSM-4, and the new clinicians will be trained and are being trained in the 5, and all licensing boards are currently using the 5. If you look at the last bullet, I think it's really something that Vic said earlier, which is the Blue Book is based on the international version of the ICD-10, not ICD-10 CM. So if you're in a group that is using the Blue Book, we'd really ask you to consider that. When we did the survey, I can't remember the number, but it was significant.
There was a few counties that reported using the Blue Book.
And so the difficulty with that is that it probably is the least connected to any of the transitions we're making. And we've actually made a formal request of DHCS to pull that as an option so that the options really are going to lead to DSM-5, so we're all using the same unified system. Though I think in transition, they would allow it if people were already doing it. We wouldn't want them to end up like denying a claim, but we don't see that as the direction that counties should be going in. The differences that they list here, I'm just going to kind of walk through them without giving a whole lot of energy. But if you either want to argue for or against it, you can look these up and go into them in more detail. But they kind of give out some of the examples of why we would or wouldn't, why we'd want to stay with the DSM-5 and not go with the ICD-10 Blue Book. Now, this grace period slide is the one that Karen Baylor pretty much put to bed for us, because we've been advocating from CBHDA with DHCS to please give us a formal grace period so that counties, we've got counties as small as 47 square miles and as big as over 10,000 square miles. We have counties with up to 10 million people in them. We have counties with less than 1,200 people in them. And the different needs and systems and electronic medical records and how they can do it and how they can train it is just all over the map. And so we've been asking for a fairly generous process that would allow any competent system of DSM, which is 4 or 5, or Blue Book, even though it's not what we would recommend, to be allowed in transition. And I pretty much think, Karen, when I walked up to her, I said, so that's what you're putting in writing, right? And she said, yeah, that's what we're going to support, is the auditors will review the system, and if you're using a competent system that's acceptable, that's what they'll use when they look at your ICD-10 submission. So I think that took a lot of the stress out of me for that.
Yeah, it really did. Although I did notice that she didn't actually say that the state was going to require the DSM-5, and I think because she related that for billing purposes and HIPAA, ICD-10 CM is all you need. Now, for purposes of guidance to the ICD-10 CM code, I think the DSM-5 is best. And I also suspect the DSM-5 is going to be best in terms of your clinical documentation to defend your billings. So that's really what we're concluding.
So an interesting thing is, well, how does this affect workflow? Is this just, okay, we'll take questions at the end. So how does this affect workflow? And so in the past, you'll see it's not unusual for a client to be diagnosed at their initial assessment, and that kind of be the standard assessment. And it generally was robust enough that that might be the diagnosis they held for months or even sometimes years. However, if you saw those specificities we said earlier, the difference between someone with schizophrenia who's stable in an acute phase, in different phases, it changes. And so we're believing that to stay accurate, that there probably needs, and there's no standard for this. And so what's here is just things that could happen. Don't think like, oh, we need to go out and do it exactly like this. But we're believing that there probably will need to be a lot more updating. Earlier, we listened about how substance abuse is now requiring, more face-to-face for the approval of a diagnostic for substance abuse with an LPHA, and different things are coming down that pike. What's coming down this pike with the DSM-5 and ICD-10 CM is a requirement to stay more current on what the actual diagnosis is, both with its severity and on the worst case scenario, you could be audited and maybe disallowed because you were leaving it at acute after they got out of the hospital, and they're saying, well, no, that's not acute now. That would be like a worst case scenario, gotcha, though I don't think DHCS is really rolling up its sleeve in that direction, but they could, especially with CMS pressures. And at the mild scenario is we just end up being inaccurate in what we're treating. And again, if we really keep working towards evidence-based practices, what you're doing with someone who's in an acute crisis is not the same as what you're doing with someone who is much more stable and needs much more life skills and other things that they can work with. So we're believing there's probably going to be a lot more review of diagnostics by the LPHAs and doctors in this process, but there's no standard set.
I think if we compared it to general medicine or physical medicine, imagine if you went to see your doctor and your doctor was with you for 20 minutes, reviewed some tests, new tests, and then you said, well, doctor, what's the diagnosis today? And then the doctor went backwards in the chart to last year to give you the diagnosis. Because because maybe when you compare it to what we do in mental health is we actually require the updating of the diagnosis once a year during the treatment plan update. How would you feel if your doctor went back 9 months to look at the last treatment plan to give you the diagnosis? Mm-hmm. That doesn't work in general or physical care medicine, and it really shouldn't work in psychiatry and mental health and substance use disorders.
Which kind of brings something that isn't on the slide, but is really something in our county right now. We're reviewing our entire IT system. And one of the things that we realize is, I was in a Google thing about a month ago, and they said something that was really kind of interesting. They said, if you talk to someone who's in their early 20s right now, they've probably never owned a desktop computer. They've owned laptops and devices and tablets like I see out here and stuff, but not a desktop. And they said, 5 or 10 years from now, if you ask someone in their early 20s if they've ever owned a laptop, most of them will never have owned a laptop. They've only owned tablets and devices that are much more mobile than that you can go instant on, be doing stuff with. We still use primarily desktops, and they're almost become like a data entry machine. It's not something that I could be out in the field and I'm seeing a client, I can pull up the doctor from another location and get them face to face because we're not working at that capacity. But actually, as I look at this, and I always think, how does this work for treatment? Because I'm not in it for treating the chart, I'm in it for treating, the person and helping them. And so we're really looking at how do we move this back into the forefront of our care. When I was a therapist, and that's what I did, I always had that information in front of me. But I send a lot of staff out in the field, and they don't have some of that stuff right with them. And so they're either going on their memory of all the people on their caseload, making sure they're really doing the right thing with that person. And so I really see this as a way of turning it on its head and looking at how we upgrade how we actually operate with our devices. There was a car accident. Somebody hit me on the freeway a few months ago. I'm in my car, and we're on the phone already. I have an appointment to drop my car off with Geico before I leave the scene. That's pretty good customer service. Wouldn't it be cool if we could do that on a home visit? That have everything done with someone you're seeing for the first time, but they're going to be in front of the doctor as soon as you can get them in because you've got it all set up because our electronics allow us to do that, and our diagnosing allows us to do that. So there's only a couple more slides, and I'll just kind of nail them down. We already talked about some of the future concerns, and in the future, you know, what could change. We talked about how so many services now may change the diagnosis rapidly, and then how do we upgrade that? And then my little shout out about if we're going to ask staff to do it differently, then we need to provide them with the right tools to do it differently, because otherwise it just rains down on them, and then both the staff and the clients suffer by not having the best tools to actually work out the system. Percy, I don't know, based on when we started, when you want us to stop. We're pretty much done with our part of the time.
Well, we're set, we started at what time did we start? 3:45, we're set to go to 4.
Probably 4:45, but I know that until the relief that was, I would describe as palpable this morning, we actually wanted to leave 15, 20 minutes for questions. So that's where we're at.
And I did see at least one person, and I was wearing my glasses, so I couldn't even, okay, I see one person back there.
There's a microphone right there, too.
You all look so much fresher now that I put my glasses back on. It's like, wow, look at you.
I was wondering if you could go back a slide that talked about the grace period. So it is very confusing. So the bottom line is there's going to be a grace period until April, and then we have to be using the DSM-5 and the ICD-10.
So the grace period has only been discussed verbally by the State Department of Healthcare Services. And in the initial discussions that I heard, the state threw out that it thought that maybe a grace period was going to be necessary and warranted, and that as long as counties did their best in terms of the documentation, that the grace period could start as early as 3 months in advance of October 1 and could extend 3 months or further after October 1. In that grace period, at one point they mentioned if you could defend your written diagnosis or your documented diagnosis in the narrative by showing a relationship of the diagnosis back to the Blue Book, DSM-4 or DSM-5, that would be okay. Okay, that you know, as long as it made sense, it was defendable. What we don't know is whether the state's going to stick to that and put it in writing, which is what we asked. We actually said, you know, you could target October 1, and we could actually share that at this conference today, too. And so we did get, you know, something from the state and Kern. Very, very much appreciated, don't get me wrong. But it's not crystal clear. I think especially of concern is some of the large counties have said, you know, they're the ones that stress the crosswalk from DSM-4, ICD-9 to ICD-10 CM. That was the easy way, basically. I don't know whether they're going to be able to go on January 1 or April 1. You know, who knows? They may say, you know, recommend to the state that they need until July 1 of next year. Personally, because I've been so tired of not using state-of-the-art equipment and tools like the DSM-5, you know, in San Joaquin County, we're going to go January 1, 2016. But, you know, we're only making our best educated guess, and hopefully we can get the state to put something in writing, and hopefully they'll make some distinction between whether they're encouraging us to use the DSM-5 or requiring us to use the DSM-5, and by when.
For us, we already implemented the DSM-5. I believe Karen gave a pretty clear message that I confirmed that although she wasn't identifying a grace period, and there's no strength in this slide. We'll probably even modify it when we post it up, because they're the ones who have to give us the definitive answer. That being said, for us, and part of the reason why we pushed it is that we were getting to the point where we were getting people coming out of graduate school that we had to retrain in DSM-4 so that they could work in our system. And then we have hospitals that are in a completely different scenario of how they're training and everything that we work with. So we just felt it was imperative just to move forward and go with 5 now. And so we're already implemented that. And many counties are looking at doing it over the next, if they haven't, within the next 6 months or so.
Yes, you talked a little earlier in your presentation about the training that you did for your staff. Could you share some of the challenges that you had doing the training on both the DSM-5 and the ICD-10 at the same time?
Yeah, I really appreciate that question. What we did is we set up, in our county, Kern County is 8,200 square miles. We're the 3rd largest geographic county. We're about 880,000 people. We're the 11th largest population. And we set up a full-day training on DSM-5 and a full-day training on ICD-10. We happened to do the ICD-10 first. We worked with CIBHS with both of those trainings. And the way we did it is we invited all of our contractors, our hospitals, everyone that would have a part in this, and we shared with them our vision of transition so they kind of knew the way we were going to do it. They all use our electronic medical record too, and so we also shared with them how the record. Now, Dan, who's on the phone, who really isn't saying anything, was instrumental in us setting this up, and it just so happens that he chairs the SWAT committee and many things, so we kind of had a leg up on what we wanted to do. But it was imperative that everyone knew that we were going in this direction. It was 2 full days of training, but we also, for example, trained some super users. And so that at certain locations where we have like a hub of assessment and that sort of thing, we would have super users, so we'd have people, and we set up a special hotline. So if anyone had any question or any problem at all, and that's where Dana came in. Dana was the one who managed our hotline for electronic medical record. And so we knew if we were getting a lot of questions on certain things, we could spit out a response to all of our providers that they would hear. Because if you've got 5 calls on something, you probably have some people who are struggling who didn't call. And so we set up all of that and then a UR of it that's going on now to make sure that our transition worked well. A lot of work.
Sounds like it. One more question. So how do you, or if you've come across this, handle, so you have, let's say 2 clinicians and it's the same DSM-4 diagnosis and they crosswalk them differently with the ICD-10 codes. Have you come across that? How are you, since the 10 has more, since it's not a 1-to-1 and the 10 has more selection?
We have this cage and it's got kind of this interesting thing, and a guy comes in and he puts one over here and one over there and he says, let's get ready to rumble. Yeah. No, actually, our quality improvement division, we've isolated what we think are some of the most difficult diagnoses in terms of having multiple choices. And there's about 10 to 15 of them we're looking at. And we're systematically beginning now to kind of pull them and see have people gone in different directions with them. And if it looks like no, actually people tend to be doing the same thing with it. But if they see differences, they're going to start looking at the assessment itself to see if it made sense. And if not, then we want to catch it early and start shaping our staff. But again, we're a little ahead of that curve. We may find that the state comes out with certain guidelines they want us to follow that may not be how we're doing it. But that's how we're doing it right now.
Remember that some of that already occurs. I mean, when you have 2 clinicians and they just reach different diagnostic conclusions. And so you have to have an internal means for sort of breaking that tiebreaker somehow, because something's got to be entered into the record. And then I think we shouldn't forget also that for the most part, the licensed practitioners of the healing arts give diagnostic impressions, and that it's physicians that diagnose.
Any other questions?
I have kind of a loud voice, so I'm not going to take the podium, but I just wanted to point out that there are other healthcare providers besides physicians who diagnose and treat patients, such as nurse practitioners and nurse midwives. So I just wanted to point that out. I've noticed that throughout the conference today. I think I'm the only primary care provider here, but I just noticed that, so thank you.
Point well taken.
Yeah, it's just that we don't have enough nurse practitioners, and I even had a trained physician's assistant work in psychiatry, just one so far. But point well taken.
Man in the back and then the woman right in the front.
Yeah, I didn't find it boring at all today because I spent half the day yesterday talking with my IT director and with my QA director, and they had diametrically opposed viewpoints on this issue. The QA director felt we should train all staff on DSM-5 and ICD-10. There was a lot of feeling that the staff were feeling a lot of confusion, there's a lot of new material, and to learn 2 systems at once just seemed extremely confusing. But that was her perception, that that's what's going to be required. And particularly following the assessment that the clinician would be expected to record both the DSM-5 and the ICD-10 coding. The IT director indicated that the county itself had done the crosswalk in the computer system that we the bill to, and that therefore all we would need would be the DSM-5 diagnosis, and then the software itself would make that crosswalk. Now, do you have any thoughts about any of that?
Yeah, and let me first honor that people are going to have different opinions on this, and that's fine. One, the reason why we chose to train together is if you look at the DSM-5, currently it does include the recommended ICD-10 CM code right there in its manual. And so contextually, we've thought it would be better to train people what they're seeing and how the crosswalk will occur versus in separate entities. And so there was a contextual reason why we trained the way we did. That being said, many people are going with electronic crosswalks. We're choosing to keep empowering and training our clinicians at a higher level so that they are making the final decision. Even though most of the time it's going to be right there, it's going to make perfect sense, but still they have the final decision if it's an odd crosswalk.
We're pretty much going to approach it the same way, remembering that some DSM-5 diagnoses end up with an ICD-10 CM choice of codes. So you can't just delegate that to a clerical staff to go, when it's this code, there's not an immediate direct one-to-one correlation. And so it has to be the clinicians in our frame of reference. And so we're actually building it into our electronic health record, so that when you put in the DSM-5, then the bubble right next to it, you hit it, and there'll be automatically a diagnosis or a choice of diagnoses, and the clinician will have to make that choice.
Well, the clinicians are involved in creating the software that does the crosswalk, so it's not like a clerical staff person. It's a clinically developed.
I get that,
yeah,
but I will repeat, it's enough so that I thought it was significant, so that there's a drop-down screen that opens up. When you put in your DSM-5 diagnosis in our software, and then a drop-down screen opens up for ICD-10 CM, and if there's only one choice, you just hit that, and that's the choice. But if there's several choices, you can't assign that to a clerical staff.
Either approach would be acceptable, is that correct?
Pardon me?
I say either approach would be acceptable, is that correct?
Depends on who you ask. If you ask the patient, I think.
I've been trying to ask the county, but I don't get very much of a straight answer. So.
I think that's why someone gets paid the big bucks.
And I could say for us, our county gave the answers to all of our providers. We didn't want our providers doing radically different things, and some doing this or doing that, because they use our electronic health record. So it only works if it's in our record. What I like about what you just said, and I didn't know you did that, is that clinicians are actually trained to go to the next thing and say, okay, if it's this, this, and this, what are my choices? And so the more we can make it intuitive to the natural training the clinicians have, the more it just becomes almost, I actually think a lot of clinicians aren't necessarily even thinking the final thing is ICD-10 CM. They're just making their final, is this your final answer? Right. I mean, they're just like they've always done when they were doing a DSM clarification.
Okay, good, thanks.
Are there actual code differences, or is it more the definition of the code? You can say a little bit more about it.
I wonder if, and Dan's been on the phone, he probably maybe has been in the weeds in this. I don't know, because I've not done that comparison myself. I don't know if you have.
I haven't either. It just makes sense to me, though, that if something was tailored for our culture, our society, that's what you would want to choose to use. And because our culture and society is different enough than what you see in China, Russia, Africa, Europe, that you'd want to use ICD-10 CM. I mean, actually it's required. It's a requirement.
So the difference is the United States takes the international version and then makes its updates. When it updated the 10, it actually updated it to the DSM-4. And so I don't know if I'm just clouding it more, but that's why there's issues between the crosswalk to 5. But I'm not even sure I answered your question.
I guess I'm just asking, I know lots of EHRs have these crosswalks, and I wasn't sure which one they would have. So it seems like if something is, got a set of codes, that code is not changeable. But then maybe the definition of how we understand that code or how it would be used, like if something needs to have occurred for 2+ years or 6+ months or whatever, that might be the difference. So I'm just trying to understand like what would be different.
So on the ICD-10, you'll never see, or on the ICD-9, you'll never see, like you see on the DSM, that something, that you had this for 6 months or at least a year. You see none of that. All it is a line of a title and a number. All that definition is going to be in your DSM. And so the crosswalk, if it's electronic, 65% of the counties right now are going to use electronic crosswalk. So if you're doing that, maybe this helps answer the gentleman in the back too. That's considered a safe methodology. Is it the most accurate? No. In the long run, will there probably be other modifications, either electronically or by choice? Yes. And I think I'll stop there.
And we know it'll be safe. Well, we're pretty sure once we have a formal announcement of a grace period that it'll be safe during the grace period. Okay. After that, I think we're hoping to get more guidance from probably both the federal and state governments.
So right now, if you're using a crosswalk electronically, that's going to be acceptable, I believe.
Yeah, you're good.
So is everyone using the same information to do the crosswalk electronically?
No, you'd have to go to the software of each electronic health record that is used by each county. Now, I think you'll find that people haven't messed with them. So Anasazi, if you have Anasazi, that's going to probably be the same. If you have one of the other products in your county, it may do it differently. And I don't know that anyone has even made any comparisons along those lines.
No, I don't think anyone has made any comparisons. I mean, it shouldn't, just by virtue of the information that you're dealing with, you shouldn't see radical changes. You shouldn't. But I want to sort of loop back to what, you guys mind? I want to loop back to what Vic was saying, too, about there being a clinical decision point, the way you guys have set it up, so that when the clinician actually makes their diagnosis, that they have to immediately go to a drop-down list to be able to compare what they see in ICD. That, I think, I would recommend that anybody that's implementing actually have that functionality built into their EHR, because it's still a clinical decision point. If it's different, and you see that it's different, then you can do something. If you have someone other than the clinician doing that, then that's just going to perpetuate any potential error that's systematic. And not to mention, cause potential problems with recoupability. But those two things go together. I just want to put a punctuation mark on that because, and that's a innovation that people have already reported doing outside of California too. This is not unusual. More and more clinicians are going to start having to entertain those two data sets of diagnosis or classification.
So in the short run, we believe, because there's some chaos involved in this, that they'll accept the electronic crosswalks, and as was said, they won't stay there. And if you just stop there for a second and go, okay, I can breathe with that for a while. And in the long run, clinicians will probably be in charge of the final diagnosis, like they are anyways. And just stop there and say, okay, and in the interim, there's going to be some odd chaos, some of which we won't know until today's October 1st, till each county starts converting with their electronic medical records, and you'll start seeing the oddities. We won't even know what they are until they start popping up like popcorn. And so I don't sleep many hours at night anyway, so it'll just give me another thing to look at.
Well, what it does bring up, what this conversation brings up, and I think it's feedback that we can give to DHCS, that I think they'll want to hear, is that when people actually start implementing the areas, there needs to be some sort of uniform way to be able to capture what's working and what's not, so that we can begin to make some comparisons, I think, across the counties of what people are struggling with, as far as to be able to manage. And I don't know if they do or not.
And that's where we're the co-chairs of the Health Information Committee with CBHDA. Dan is on the phone. He does that from the phone and manages the SWAT team, which goes really into the weeds on this stuff with DHCS. And so if anything comes up as you're making your conversions, please, if you're not county, if you're a provider, please pass it into your county system verbally, have them push it forward to us. we are not experts in this, but our job as directors, and why we're there, is that our job is to help counties deal with these things along with the state.
Right, and you know, for the most part, in county land, you're using one of 3 software providers, and you belong to user groups, and your user groups are, you know, should be cooperating so that you're coming up with exactly, or if not very near exactly, screens. So they shouldn't be too divergent, because then we're going to drive the state nuts. But what's going to compound the issue statewide is then we have a very robust contractor network throughout the state, and they're using a host of different softwares. And to get them all to talk to each other is something that has been on our agenda. It's a difficult one to find a real quick and easy remedy to. I mean, interoperability is all the rage, and yet, and we have some, but we don't have enough. And so that's going to be a hindrance to us all getting on the same page, as Percy suggests, and I wholeheartedly agree with him. It's just a hard thing to do when everybody's using a little bit different tool.
So I have a final joke for you. You know, you laughed so hard at my first one, that you just took you through the ITology of DSM and ICD. And none of them are laughing.
Keep working at it, Bill. Keep working at it.
Yeah, ITology. IT.
She laughed at the other one, too.
Percy, are we good?
You guys are good?
Okay.
So, any more questions? Any last questions?
I just have one last question. You were mentioning about the CIBHS training. We had some training as well in my county, which is Fresno. Is there any current or future planned SUD-specific training? We have some interest from our very robust network of SUD providers to have some training on DSM as well as the billing code.
We have just been getting a small flurry of these requests, so that is something that we're actually planning to do relatively.
There's a lot of concern about medical necessity and making sure that we're establishing everything.
Yeah, it's a different framing. It's a little bit different framing. You're ultimately going to be dealing with a bunch of the same information, but it is a different framing.
When there's something developed, would there be a notice out to all counties?
Yeah.
I know a lot of us are sort of waiting with bated breath.
We will disseminate information, but it's something we're actually looking at.
So you're only going to train on county level, or do you train on provider?
No, we train up for provider level at the county level. I mean, obviously, it's easier sometimes to coordinate large trainings, on a county level, but we can do that on the provider level as well.
So we really appreciate, I mean, this was a long day, and if you were here yesterday as well, and training zaps you in a way differently than doing work. And so we appreciate that you hung in there with us on what I think is a fairly dry subject matter, but vital to us. So thank you very much.